releasing hormones. Then you have TRH, okay, thyrotropin releasing hormones, CRH and GnRH. So these are influencing the release of the hormones from anterior pituitary, whereas there are also a set of your inhibitory hormones like your dopamine and somatostatin, which is actually inhibiting the release of the hormones from anterior pituitary. Okay, so you see your hypothalamus is controlling the release of the anterior pituitary hormones. So from anterior pituitary hormones, you have the release of different types of hormones, mainly your growth hormone, and you have thyrotropin stimulating hormone, then you have adrenocorticotropin hormone, then you have LH, that is luteinizing hormone, and FSH, that is follicle stimulating hormone. Okay, so these are all the hormones that is released, and also your PRL, that is your prolactin hormone. So these are the sets of hormones that is released from your anterior pituitary hormones, and when they are released, they will be traveling through the circulatory system to reach their different target organs, okay, and thereby providing or thereby causing the different kinds of the actions. Okay, so yeah, anterior pituitary hormone, it is the master endocrine gland, and it elaborates a number of regulatory hormones. It is to say that they have there are different important kind of hormones that is being released through the anterior pituitary. But however, the hormone release or secretion from the anterior pituitary is controlled by hypothalamus through the release of different sets of your releasing or release inhibitory hormones. Now, each anterior pituitary hormone is produced by a separate group of cells, and there are cells divided according to the staining capabilities that they have, and they are generally divided as the acidophils or the basophils. So coming on the acidophils, you have the cells producing growth hormone, which are called somatotrophs. Similarly, the cells releasing the hormone prolactin is called lactotrophs. And under the category of basophils, you have the cells that is releasing the hormone FSH and LH are gonadotrophs. Similarly, your TSH will be released by sets of cells called as thyrotrophs, and for the hormone ACTH, you have a set of cells called as corticotroph. Okay. So if you have to list the numbers of the hormones that is coming through anterior pituitary, you have one is your GH, that is the short form for growth hormone. Second one is prolactin. Okay. The third one is THS, and fourth one is the TH. Fifth one is FSH, and sixth is LHS. So the FSH and LH, they can be collectively called as gonadotropic hormones. Okay, so you have to remember this 6 numbers of the hormones that is related to anterior pituitary. And now you have to learn about the drugs that can regulate the release, or that can regulate, or you can say which are related to this hormones. Okay. Okay, is that clear? So you have to go through this 6 different types of hormones. You have to study about the drugs that is related to these hormones. Okay.
Yes, ma'am.
Okay, then this is basically a slide which is depicting the metabolic functions of the anterior pituitary hormones. So you have a hormone called as thyrotropin or TSH, which will be acting on thyroid glands. Okay, so this will be the target tissues or the glands for your hormones, that is a TSH coming from anterior pituitary, which will be now responsible for the production of the thyroid hormones from this gland. Then you have a growth hormone. Okay, so growth hormone especially is responsible for stimulating the postnatal body growth. Okay, then you have ACTH hormone. This will be responsible for the stimulation of production of different other hormones and androgens by the adrenal cortex. Okay, so mainly the target gland will be the adrenal cortex, which will be responsible for production of different other hormones like your glucocorticoids or your sex hormones like your gonadotropins. Okay, then you have FSH and LH, that is mainly acting on the uh, ovaries or the testes and responsible for your that will be responsible for the development or regulation of spermatogenesis in testes, and also responsible for the development of ovarian follicles in the ovary. Okay, so this will be mainly responsible for your reproduction area. Okay, and also your hormone, which is your prolactin, which will be essential for milk production by the lactating mammary glands. So first, in today's class, we'll be talking about the growth hormone and the prolactin. So the growth hormone, if you see, okay, it is an anterior pituitary hormone, okay, which is required for both postnatal period. You see, postnatal banda both in the childhood as well as in adolescence for the attainment of adult size, normal adult size, that is for the growth. Okay, and has also beside the growth of to be achieved, okay, in the adulthood or in the adolescence, they are also a very important hormone that regulates the carbohydrate metabolism, lipid metabolism, and also important effect in the protein metabolism also. So besides what I mean to say here is the work or the functions of the growth hormone is not only limited for only the growth or only the for achieving the normal adult size or anything like that. So beside that, they have the important function also for the regulation or effects in your lipid and carbohydrate metabolism. So the work or actions of the growth hormone is mediated through the intermediate compound or intermediate thing called as somatostatin C, or also known as IGF-1, that is your insulin-like growth factor. So this is an intermediary compound which is helping to regulate the functions of the growth hormone. Okay, is that clear? So this is the thing, okay, insulin like growth factor 1. Okay, so as we have been talking, the main function of the growth hormone will be for the attainment of the normal adult size. Okay, so that is mainly helping for the linear growth. And in this, they mainly works on chondrocytes, where they increase the DNA and RNA synthesis, the protein synthesis, the collagen synthesis, so as to maintain or regulate the optimum linear growth with increase in cell size and number. Also, it helps to increase the lean body mass. Okay, and in this, the muscle, how they do is that in the muscles they will decrease the uptake of the glucose or increase the amino acid uptake, and also increase the protein synthesis. So with this thing, they help in regulating or achieve the lean body mass. Okay, also in adipose tissue, they help to decrease adiposity. So you see, apart from the work of or the action of the growth hormone in attaining the normal adult size, okay, they also have an important effect that is there in your lipid and the carbohydrate metabolism. So you see, it is decreasing the glucose uptake, and here also in adipose tissue, they decrease the glucose uptake and increase the lipolysis, because of which they decrease the adiposity. Okay, by this way they maintain this metabolism of lipid and glucose. Also in different organs and tissues at the level of organ, like in various organs like your kidney, pancreas, intestine, skin, okay, bone, heart and lung. They also increase the DNA, RNA synthesis, increase the protein synthesis. So all of these activities or the action of the growth hormone, they what they do is they will increase the organ size and function, and ultimately they help in achieving the normal adult growth size. So the pathophysiological involvement. As we have been talking about the drugs which can alter the effects of this hormone. So what we need to learn is what is happening when these hormones are deficient or they are excess in amount in the body. Okay. So when the growth hormone is deficient in a body, they give rise to a condition known as dwarfism. Okay, and when they are increased, they are called as gigantism. So when they are less or when there is deficiency, there will be the height will not be increased, the normal adult size which is not achieved, and that is called as your dwarfism. And when this is excess amount, excess of it in the body, so this the stature will be far more above your normal adult size, and that is called as gigantism. So this gigantism occurs when in early life. Okay, but when it is an adult, if the growth hormone is kind of your increase in the adulthood, they give rise to a situation called as acromegaly. So this is different from gigantism because acromegaly, it is happening after adulthood. Okay, that is in adulthood, whereas if it is occurring in early life, that is called as your gigantism. So acromegaly, it basically occurs during adolescence or in adulthood. That is when the epiphyses of the long bone have already fused with the sacs. Okay, so what is happening here is the person is not able to grow taller, but the bones can become thicker in the sense. Okay, so are you getting this point? So your gigantism. So what? Okay, so gigantism occurs only in the early phase. If it is occurring in the early phase, it is called gigantism. But if it is bound to happen in adulthood, okay, when the epiphyses of the long bone have already already fused with the shaft. So what is happening here is the person will not go taller. Okay, the person cannot go taller, but the bones are bound to become thicker, as you can see in the picture here. Okay, so this enlargement, especially is seen in the nose area. You see the bones have been become in the areas of the forehead, in the supraorbital regions, and also in the lower jawbone. Okay, so that's the difference between your gigantism and acromegaly. Gigantism occurs in the early life, whereas acromegaly, it occurs in the adulthood. So adulthood, already your epiphyses have joined with the have fused with the shaft, so there is no the persons are not bound to become taller, but what is happening is here the bones will become thicker. Okay, and this is mainly seen in the areas of your forehead, okay, in the noses, in the supraorbital regions or ridges, or even in the lower jaw. Okay, so that is acromegaly. Both situation is a situation of excess of growth hormone in the body, but the difference is that one is occurring in the early life and the other is occurring in the adulthood. Okay, is that okay?
Yes, ma'am.
Okay, so what we'll now learn will be the drugs which are there to inhibit or facilitate the release of this growth hormone. Okay, so you have growth hormone analogs. So one is called as somatropin, and the next one is called somatrin. So this means like they are growth hormone analogs, means they are produced externally, okay, in the labs, okay, the drug like to produce the same effects like that of growth hormones. So can you say where it will be used when you will be administering the growth hormones externally? Will it be used in dwarfism or will it be used in gigantism? So are you clear about my question? My question was, if these drugs are your growth hormone analogs, in which situation will you give or administer this kind of drugs? In a kind of your deficiency situation, or when your growth hormone are already there present in the body?
Deficiency disorder.
So deficiency means your the
Dwarfism and gigantism.
sorry.
Dwarfism.
Yeah, so you will be giving in a situation when there is growth hormone is deficient, okay, and that situation is known as dwarfism, okay. And also in various syndrome it is given like a Prader-Willi syndrome. So this is a kind of a genetic disorder, okay, and which is characterized by your symptoms like your weak muscles, poor feeding, and slow development, okay. Failure, there will be failure of growth, obesity, and glucose intolerance. So they can be given, okay. So this somatropin and somatrin, they can be given to facilitate the development or the growth, okay. Similarly in Turner syndrome, this is also a genetic disorder which is affecting mainly the females, okay. And this is also in this syndrome also the females affected shows short height, okay. The failure, there is failure to of ovaries to develop, and also heart defects are there. But here the preparations are mainly given to increase the height and muscle mass, okay, because they have both, they have the anabolic effect. And also in muscle wasting in AIDS, in your chronic illness like your AIDS or burns, to have that anabolic effect also, it is given in this situation. So coming to the adverse effects, okay, so these are given through your like your IM and IV injection. So with those things, the pain at injection site will be one of an important adverse effects associated with the use of these drugs. Similarly, lipodystrophy, glucose intolerance, okay, hypothyroidism can also be seen, salt and water retention, hand stiffness, myalgia, and headache will be the adverse effects. So another group of the drugs are called as your growth hormone inhibitors, and they are inhibiting the release of the growth hormones, or they will be antagonizing the effect of the growth hormones on its receptors. So these are the drugs like your somatostatin. So somatostatin, as you have noticed is in one of the slide, that somatostatin is also your physiological inhibitory releasing hormones that is coming from the hypothalamus, which inhibits the release of your growth hormone from anterior pituitary. And other analogs of the growth hormone inhibitors will be octreotide and pegvisomant. So somatostatin, this is the physiological one. Okay, so this is released from the hypothalamus. So these are the release inhibitory hormones released from hypothalamus, which are actually controlling the release of the growth hormone from anterior pituitary by inhibiting its release. Okay, and when this same thing is produced as a drug, okay, so this is called as your exogenous somatostatin. But this exogenous somatostatin, this has various disadvantages. One was they had very short half-life, okay, that is about 1 to 3 minutes, because this is one of the disadvantages. It means that if it has a very short half-life, you need to administer the drug at a very frequent intervals, okay, and that becomes one of the disadvantage. Next is lack of specificity for inhibiting growth hormone only. So this is not growth hormone specific. They are also related to your other hormones like your thyroid stimulating hormones, okay, so they are not specific only for your growth hormone. And on discontinuation, the rebound growth hormone rebound formation is there. So this will be the disadvantages make made it so limit made it to be have only a limited use in clinical practice, and therefore many other analogs that is working similar to somatostatin have been developed, and one of those is your octreotide. Okay, have you gotten the point? So somatostatin is exactly like your physiological hormone, but with this comes a very there were important disadvantages relating to it, like your lack of specificity for growth hormone, and also they had a shorter half life, and because of that reason, your longer analogs and better analogs for your growth hormone inhibitors have been preferred. Okay. Is that clear?
Yes, sir.
Okay, so you have octreotide, which is a growth hormone inhibitor analog, and here it is a very having a longer half-life, and it is also a very potent drug. So potent drug means you can give it at a very smaller dose compared to the other one, and therefore your adverse effects succumbed will also be very much less. The important uses rather than your in conditions where it is related to growth hormone. So users will be your esophageal varices. So can you remember we have talked this in the renal block also about esophageal varices. So can somebody explain about esophageal varices?
When there is a portal hypertension, there is a dilatation of the vein in the lower part of the esophagus and
Okay.
rupture occur and hematemesis occur.
Okay, so what was the drug that was preferred in esophageal varices? Can you remember that? Which group of drugs for this? So that was your antidiuretic hormones category. Okay. So because they have also the ability to constrict the splanchnic vessels, okay, so as he have said, okay, I have already talked about this in your antidiuretic lessons also, that in the situations where there is cirrhotic liver or kind of your liver disease, your portal hypertension comes in, and because of which the pressure develops mainly in the lower one-third area of the esophagus. So blood draining system or the blood vessel system there, the blood vessels will get dilated, and a ballooning of the vessels takes place, which is called as varices. Okay, so that is called as, that's why they are called as esophageal varices. So because of this dilatation and ballooning of these vessels is taking place, okay, there are high tendency that this, because of the inbuilt pressure, because of the portal hypertension in this cirrhotic liver condition, okay, they will get ruptured, and a massive bleeding can occur. Okay, so that is your esophageal varices. And what you need to do here for the treatment of this condition is that you need to constrict those vessels. Okay, and strong vasoconstrictors, or your even the drugs which can constrict these vessels can be used. So that will be one of your drug category will be your antidiuretic hormone analogs, and the other one is your octreotide. So octreotide is your drug group from which category? How will you classify the drug octreotide?
Growth hormone inhibitors.
Growth hormone inhibitors. Okay, So similarly, they can be used for acromegaly, gigantism, okay, and also they have been found to be very helpful in the secretory diarrhea that is associated with very tumor conditions like your carcinoid tumor, AIDS, and cancer therapy, mainly by decreasing the release of the hormones. So adverse effects includes nausea, vomiting that can occur, steatorrhea, stasis in gallbladders, okay, and very important adverse effect will be the with the chronic use of the drug there can be the vitamin B12 deficiency. So another analog, which is the actually the antagonist of those receptor, growth hormone receptor, that is called as pegvisomant. So pegvisomant, the name is given because these are your polyethylene glycol. So PE comes from polyethylene. These are kind of your compounds that get attached to the compound of the growth hormone. Okay, so polyethylene glycol is sorry. So polyethylene glycol is complex with your growth hormone. That's why the name is given as your polyethylene glycol pegvisomant. Okay, and these are growth hormone receptor antagonists in the sense that they are antagonizing the receptors for the growth hormone and blocking the actions of the growth hormones on their receptors. And these are used in those cases of acromegaly where other treatments like your radiation or other drugs like your octreotide or somatostatin have become ineffective. Okay, so that was about growth hormones. So growth hormone, you have growth hormones and the growth hormone inhibitors. So what was the name of growth hormone analogs? There were two drugs which was used mainly in in dwarfism. What were the name of the drugs?
Somatropin and somatrin.
Somatropin and somatrim, and you have growth hormone inhibitors, and you have the drugs like
Somatostatin, octreotide, pegvisomant.
okay, so you have to learn about this drugs. Okay, so next is your drug called as so this is not drug, actually your prolactin hormone. Okay, and you know that this is the main hormone that is essential for production of the milk by the lactating mammary glands. Okay, so prolactin is a principal hormone that is responsible for lactation, and they are responsible or they promote the proliferation of the cells in the breast, that is the mammary gland, and induces the synthesis of milk proteins and lactose. So mainly you have to the thing is that this is the hormone produced by the anterior pituitary lobe that is mainly responsible for the production of the milk. But however, what is happening is that the secretion of prolactin. So you see, after birth only there will be release of these hormones. Until that period in females, what is happening is that your prolactin is under the tonic inhibitory control of hypothalamus. There is a thing called as dopamine, which acts as a neurotransmitter, okay, in the brain areas, which is inhibiting the release of the prolactin. And after the birth of a child, okay, what is happening that this inhibitory control through dopamine will be inhibited or they will be released, and therefore now prolactin becomes acting, and because of which it is only then responsible for the milk synthesis through the lactating mammary glands. Is that clear? Am I clear on this? You have to know that dopamine is inhibiting the control of the release of prolactin. So for the pathological involvements, if there is deficiency of your prolactin hormone, the mammary glands, they fail to lactate, that is they fail to produce the milk. And if there is excess of production, there is this condition known as hyperprolactinemia. Okay, excess of prolactin causes hyperprolactinemia, which is characterized by galactorrhea. And there can be galactorrhea, means more of the milk production, and there will be amenorrhea and infertility. So if you see physiologically also, when a person starts to lactate, okay, there is a phase of your infertility. There is a phase where, okay, there is a phase of amenorrhea and infertility, because excess of prolactin in the body, it eventually it inhibits the gonadotropin releasing hormones from the hypothalamus, that is GnRH, okay. And when this releasing hormones will be inhibiting, what is there is that your what is there is that your gonadotropes like your FSH and FHS stops its function, okay, because your GnRH is being stopped, is being the release is being stopped because of your high prolactin release, and therefore it gives a state of amenorrhea and infertility. Okay, am I clear?
Yes, ma'am.
So you don't have a drug like kind of your prolactin analogs, but what you have is a group of drugs coming as your prolactin inhibitors or dopamine agonists. So can you say why they are named also as dopamine agonist? So why they are called as dopamine? DA means dopamine. It's a neurotransmitter that is have various functions in the brain. Okay, so dopamine agonist, the name is given because they are inhibiting the release of prolactin. So it acts as your prolactin inhibitors. And in this category, you have two derivatives. One is derived from a source of ergot. So they are called as ergot derivatives, and the other one is your non-ergot derivative. So in the ergot derivative, you have important drug name as bromocriptine, also your drugs like cabergoline and pergolide. So these two drugs will be important in your while studying your CNS disease, which is called as Parkinsonism. And what you have to know about the prolactin inhibitors mainly will be bromocriptine for your prolactin inhibitors in the endocrinology. So bromocriptine, it is a dopamine agonist. It mainly acts through your dopamine D2 receptors. So you have various receptors for dopamine, D1, D2, D3, D4. Okay, so they main acts through your D2 receptors. So as you all know, bromocriptine now they will decrease the prolactin release from pituitary. Okay, because dopamine is that neurotransmitter which is responsible for inhibition of prolactin release from pituitary. So there is a contradictory thing here with the growth hormone that goes on. Okay, so what is found in normal individuals is that it increases the growth hormone release, but same bromocriptine, if it is there in if you inject or if you give it in acromegaly, the condition of your excess of growth hormone, then it is actually found to decrease the growth hormone in acromegaly. This is like your dual effect it has. Okay, and also it has anti-Parkinsonian effects. So Parkinsonism is a CNS condition disorder which is caused actually because of imbalance between your neurotransmitters like your dopamine and acetylcholine. Okay, in this situation, your dopamine, there is high activity of the acetylcholine, okay, which you have, and there is lesser of your dopamine activity going on, which gives a various of symptoms that is there in Parkinsonism. And one way of treating the Parkinsonism disease is to increase the activity of the dopamine neurotransmitters or the activity of dopamine. Okay, and that since these are your dopamine agonists, so they will also have a very important actions or important effect in the treatment of Parkinsonism disease. Okay, so this will be very clear when you are going through your CNS block. Already I have told you that these two drugs, cabergoline and pergolide, will be the important one when you study it in your Parkinson disease. And also it stimulates the dopaminergic receptors in CTZs. There is a zone, a chemoreceptor triggering zone, okay, and they have dopamine receptors in it. So this you have already must have studied in your GI block about the CTZ center and how your these dopamine receptors are located there, mainly your T2 receptors. And when they are stimulated, they also cause vomiting. They are also responsible for producing hypotension and also decreases the intestinal motility as well. So the main uses of these are kind of dopamine agonist or your prolactin inhibitors will be in hyperprolactinemia, because you need to decrease the synthesis or decrease the release of this, not the synthesis, release of these hormones. So that will be your hyperprolactinemia. Okay, and then acromegaly. So why it is used in acromegaly? Can anybody say why acromegaly is one of the uses for bromocriptine? Anybody?
It inhibits the growth hormone release.
So it decreases the growth hormone release in acromegaly, but in normal individuals, it is found to increase the growth hormone. Okay, that difference you have to know. And Parkinsonism, as we have discussed, that they are in Parkinsonism, what is there is the imbalance between two neurotransmitters there, that is dopamine. Less of the dopamine activity is happening in Parkinsonism, and to correct that, what we can do is the increase of activity of dopamine. So because this is a dopamine agonist, this group of drugs are a very useful group of drugs that is used in the treatment of Parkinsonism. So coming with the adverse effects for bromocriptine, nausea, vomiting. Vomiting will obviously be there because they stimulates this dopamine receptor in CTZ center. Then constipation, because it decreases the intestinal motility. Again, coming is hypotension. Okay, and these are your immediate effects. But with the late effects, what will be there is, because your dopamine is actually your neurotransmitter that has various function in regulating the important functions of the brain. So with the late effects will be coming the behavior with the excess of dopamine that is going on there. So there can be behavioral alterations, mental confusion, and if it is very much higher, okay, if the dopamine is very much high, it can also give rise to psychosis or schizophrenia. And there is a skin disorder also that can happen. Okay, it is, you can see there's kind of bluish net like pattern can develop, especially in the legs. Okay, this is like your adverse effects relating to the skin, where the net like pattern develops, especially in the legs, and this particular condition is called as livedo reticularis. Okay, is that okay?
Yes, ma'am.
Okay, so I think I'm going to stop here. Okay, so what we have learned about today about the anti-pituitary hormones are the two sets of hormones, that is your growth hormones and the prolactin. Okay, in growth hormones we have studied about both the growth hormone analogs and growth hormone inhibitors, and in the prolactin there are only the drugs which are effective. They are not like prolactin analogs, but they have the prolactin inhibitors, that is your dopamine agonist. Okay. So if you have any questions or queries you have not understood, so everything is fine then. So I have some questions as MCQs in there. So can you please read out and say the correct option or answer to this? So question number 1 is, several actions of growth hormone are exerted through the elaboration of A, cyclic AMP, B, cyclic CZMP. Okay, that is, next is somatostatin, and D is insulin-like growth factor 1.
Insulin-like growth.
So that's the insulin-like growth factor. Okay, the actions of the growth hormones, they are elaborated through your intermediary compound called as IGF-1, or also called as somatostatin C. Okay, so what is somatostatin? So your answer would be insulin-like growth factor. But what is somatostatin? Can anybody say what is somatostatin?
Inhibitor.
So these are growth hormone inhibitors. Okay, they are not your growth hormone analogs, but the inhibitors like your octreotide and pegvisomant, which will be used in your acromegaly and gigantism. Okay, so that is there. So next is somatostatin inhibits the release of growth hormone, insulin, thyrotropin, or all of the above.
All of the above.
Yeah, this is a very tricky question. Okay, so the answer would be all of the above. Okay, so somatostatin is a growth hormone inhibitor, and we are bound to think that they are only inhibiting the release of growth hormone. Okay, but the disadvantages that we have talked for the somatostatin, one is that it has a very short half-life. Okay, and next is the lack of specificity for the growth hormone. Okay, so somatostatins not only inhibits the release of your growth hormone only, but they are inhibiting or having the effect on other two hormones like your thyrotropin and also with insulin. So the answer would be all of the above. Okay. So the third one is bromocriptine causes the following: prolactin release, vomiting, uterine contraction, and impotence. So what is bromocriptine? Anybody? What is bromocriptine?
Prolactin
Prolactin
inhibitors.
inhibitor.
Prolactin inhibitor. So what does it do? It causes prolactin release, yes or no?
No.
No. So it actually inhibits the release of prolactin. You know? So this will be not the correct option. Does it cause vomiting?
Yes, ma'am.
So that will be
Yes, ma'am.
stimulation of your dopamine, maybe your dopamine receptor in the chemoreceptor triggering zone. So vomiting is the option. Okay, correct option. So there is no thing going on in uterine contraction or impotence. So the correct option will be here. What is the correct answer? So that will be vomiting. Okay. So we will continue with the next hormones. That is your TSH, then ACTH, FSH, LH, gonadotropic hormones in the next session. Okay.